Welcome. My name's Stuart. I'm the head of the Justice Health Unit at the University of Melbourne and the Murdoch Children's Research Institute. And it's my pleasure to welcome you to this, the fifth in our series of 6 webinars on COVID-19 and detention. I'm going to just start, as we always do with these webinars, by acknowledging the traditional owners of the country that we're on. So for me, that's the land of the Bunurong people in the Kulin Nation. And I'd invite you to pay respects to the traditional owners of the lands where you're on at the moment, and to pay respects to their elders, particularly when we're talking about issues of incarceration. These are very, very important issues to think about in terms of our First Nations peoples. And so we're very pleased to have some people speaking on those issues today. I'm going to start, if I can get the tech working, with some acknowledgements before we get on to the content for today. So these webinars were co-funded by ourselves, by the Justice Health Unit, and by the Centre for Health Equity at the University of Melbourne. And I want to thank particularly Louise Sutherland, who in Perth, who's done a lot of hard work to bring these webinars together. We're very fortunate to have senior busy people for all of our webinars, including this one, and it takes time to line up a time that's going to work for everyone. So thanks very much, Louise, for doing that and for making this happen. And the others in our team who have been involved in doing this: Claire Keane, who's recently moved to a fantastic position at the Australian Institute of Health and Welfare, Lindsay Pearce, Elena Vasey, and Claire Chiminello, who's working in the background to make sure everything works today. And also Tihin, who's our tech support, long-suffering and very supportive. He'll be in the background throughout this webinar as well. So the overall aim of this webinar series is to just reflect on the policy and operational responses to COVID-19 in places of detention so far. And obviously, you know, the way this has happened has been rapidly evolving, and we started these seminars in July of last year, and obviously a lot has changed in that time. But throughout the series, our aim is to identify what's been missing from the responses so far, and through reflection on that, develop some recommendations for what we think of as probably comprehensive, sustainable, cross-governmental responses to COVID-19 in various places of detention. So as you can see on the slide, we've had 4 webinars so far. The first in July last year, starting with a global overview with speakers from WHO, ICRC and other places. The second one focusing on COVID-19 and decarceration, so the extent to which COVID-19 creates new arguments for reducing incarceration rates. The third was focusing on rights, accountability, information and standards. And then the fourth one, a little before the end of last year, was on immigration detention and COVID-19. All of those webinars were recorded and are available on Justice Health Unit website, and we invite you to take a look at those if you're interested. So the 5th webinar, the one for today, is focusing on our own patch of the world, on the Australasian region, which means Australia and New Zealand. The last webinar, which will happen in the next month or 2, is trying to bring all that together and think about international responses and next steps in terms of our response. But on to today, I just want to very briefly introduce our 5 really outstanding speakers. We're thrilled to have them with us today. The first, and this is the order in which they'll speak, the first is Larissa Strong, who's the Acting Commissioner for Corrections Victoria, then John Hancock, who's the Chief Legal Advisor for New Zealand Human Rights Commission. The third speaker will be Erik Monasterio, who's a consultant in forensic psychiatry and a senior clinical lecturer at the University of Otago on the South Island. Thank you for making that clear, Erik, not the North Island. We'll have some New Zealand Island tension in this webinar. Our fourth speaker, someone I've been fortunate enough to run into in this sector over a number of years, is Roxanne Moore, who's a Noongar woman and a human rights lawyer, and also the Executive Officer of the National Aboriginal and Torres Strait Islander Legal Services. And then wrapping it up, our 5th speaker, someone who also has been in this sector for a very long time, Dr. Mindy Sotiri, who's the Executive Director of the Justice Reform Initiative. So each of our speakers will speak for about 7 minutes, quite a short presentation. And throughout that time, we'll invite you to comment, to send questions, comments through the chat function. What we'll try to do is just go through those presentations without pausing for comments and questions, with a view to saving a good chunk of time for discussion after the presenters have finished. Then Lucas, I'll hand over to Lucas, who will facilitate a question and answer session. So throughout this webinar, please feel free to send comments or questions. We invite them, we look forward to them. We'd really like you to contribute and participate in this as much as possible. So with no further ado, I'll introduce our first speaker. Again, someone who I've been fortunate enough to run into in this sector for quite a while, Larissa Strong, who is currently Acting Commissioner for Corrections in Victoria. Larissa, over to you.
Someone had to do it, so I thought I'd get it over and done with. So thank you, Stuart. I'd like to start by acknowledging the traditional owners of the land in which I'm in, so the Wurundjeri people of the Kulin Nation, and pay my respects to their elders, past and present. Stuart, if we can just go to the first slide, just by way of context, a bit of scene setting, the introduction slide. Corrections Victoria is the business unit of the Department of Justice and Community Safety that's responsible for the management of the prisons, the adult prison system in Victoria, as well as community correctional services and post-sentence supervision and residential facilities. We have all up 11 prisons in Victoria, but there's actually 16 facilities because 2 prisons have annexes. So there's about 16 prison facilities that are within Victoria that we're responsible for, of whom 3 are private prisons and the rest are state-run public prisons. And I'll really focus on prisons, I think, for this presentation. In terms of the number of people that we have in prison, we have 6,718 male prisoners and 414 female prisoners. That number's down, and one of the interesting things about COVID, partly in response to, I suspect, to lockdown and reduced recorded criminal activity and police activity, plus then court changes, is we have had a 12% drop in our prisoner numbers over the past 12 months, we think directly related to the lockdown measures. That's all. I guess Corrections Victoria, we work obviously in partnership with the health service providers, education and TAFE providers, and our own internal clinical psychologists to support rehabilitation, but also safe and humane treatment of people in our care and in our custody. We can just go to the next slide. So that's just a little bit of an overview to give you a sense of what we're looking at in terms of adult correctional systems in Victoria. In terms of our response to COVID, I guess we were a little bit lucky in that we had a little bit of advance notice, given, you know, Australia was a little bit behind the rest of the world, and we started to prepare for what would this mean for prisons really in February, starting to do that thinking with a number of changes made in March, which was very fortuitous. So on 21 March, we suspended face-to-face visits for people in custody, and that was done at a national cabinet level. All state jurisdictions and correctional agencies coordinated that reply into responding and suspending the face-to-face visits. We did that in a way that at the same time we suspended the face-to-face visits, we did bring in technology like tablets and iPads to support virtual visits and Zoom visits to maintain family connections and support throughout that time. It's always been a really delicate balance for us, balancing what do we do to minimise the public health risk with trying to also have an environment that's as humane and least restrictive as possible, and it's not always easy to get that balance right. The other thing that we did early in March is we did introduce protective quarantine. So for all people coming into the adult prison system from the community, normally they come to us from police cells, we do get some higher court gains. We introduced a 14-day protective quarantine regime with testing on day 1 and also testing on day 11 and awaiting medical clearance on day 14 before those prisoners coming from the outside were able to intermingle with the rest of the prison population. At the same time, a number of infection prevention and control measures were introduced, such as the touch point cleaning and the deeper cleaning, and we did extra training. And one of the things we learned as we went along was at one point we very quickly contracted a lot of cleaners. As we, I guess, learned about some of the experiences with hotel quarantine, we shifted that and we got TAFE in to train our prisoners to do the COVID cleaning in the areas that prisons can go. And so in terms of giving them a skill, but also giving us, I guess, probably a cleaning workforce where we had, more confidence that they weren't accidentally bringing the virus in with them. And the other thing I think that was a big feature of our COVID response was the enhanced use of technology. I think I've alluded to it in terms of we use tablets to support maintaining connections with your family and with your friends. We also used it to support service provision. So what we actually found in wave 1 is a lot of service providers withdrew of their own accord due to their own workplace requirements. And it's interesting, we think of prisons as closed environments, which they are, but it's amazing how many external service providers you have into prison on any one day. And then when suddenly they all drop off, and how do you can maintain that connection? So tablets were also used to support service delivery throughout that time. When we introduced protective quarantine, I should say, we also set that up with a protective quarantine service delivered by our psychologists and social workers that we employ to do proactive wellbeing check-ins on people, checking in on the 24 hours, on 48 hours to see how they're going, as well as activity packs and things to try to, I guess, mitigate, the impact of people of being in a cell for 14 days with limited out-of-time hours in that process. What we also found was wave one was a good, we were lucky, wave one, and I think it reflected who was getting COVID in the Victorian community. So this won't surprise Stuart, but we're very much, we mirrored the community. So in wave one, when it was returning overseas travellers who'd been on cruise ships, we weren't getting people coming into custody testing positive in that process, or even our staff in that process. So we put in all these processes, which I think was really great, because when we came to wave two, it really became very real for us. And there was a different cohort who were getting COVID in the Victorian community, and they were a cohort that were coming into us in the prison system. So what we found in wave two, and I'm trying to remember when our first case was, I think it was in July, we ended up having 24 prisoners detected as having COVID positive when they came into our prison system, either detected in police cells or with us on protective quarantine through that process. All of them were men. They were all pretty much young men, and most of them were asymptomatic. They didn't even know that they had it. And we had a couple whose day 1, day 3 test was negative, but their day 11 test was positive. So I do think that's significant. The other 4 cases I wouldn't really worry about. They were, we did blitz testing in one of our prisons in May, and it picked up 4 cases that had very small traces of positive. Their subsequent tests were negative. So we're regarding them as being a false positive, though we're really not allowed to say that, but they were. So what I think is interesting to know is we did have 24 prisoners positive in our system that came into us, and we haven't had prisoner-to-prison transmission. A real focus of us has been from very early back in March about our number one thing needs to be we have to stop COVID getting in as much as possible, and then should it get in, minimise the risk of further transmission once it's through that process. And that precautionary principle has kind of impacted all of our decision-making and been one of the principles that we've looked to do. The other thing that we did do, I will mention, was we're very conscious of also releasing people in the middle of a pandemic. And, as you know, if we have someone who's due out, we must release them. We cannot hold someone longer than possible. So we set up a bespoke transportation service for anyone who needed to be released so that they didn't have to get public transport home, so we could actually take them home. We also had that service available to take people who we knew were COVID positive that we would have to release through that process. And remembering in Victoria, wave 2, we were having 700 people a day that were testing positive, and we were in lockdown. So that service started to get increasingly utilised. We even had one case where a man was in getting his bail hearing. He got told he was being granted bail the same time that his test results came back in as positive, and we had till midnight to release a positive prisoner who didn't want to go home to his family and risk them. So we're fortunate in having that service that could actually safely transport someone who was known to be COVID positive. We also invested in further supported accommodation for people. We set up Maribyrnong, the old immigration centre, as a transitional support centre for men exiting prison at risk of homelessness during the pandemic, and that's still operating. So that was another feature about thinking, how do you appropriately release someone during a pandemic? Go to the next slide, if that's okay, Stuart. So I guess in terms of what worked, I think really, it was actually quite hairy in wave 2, and it was a very busy process. But I think the preparation and the planning that was done back in February was really critical. The fact that we had tested our systems, we were lucky. We were linking in with Justice Health, we were linking with the Department of Health and Human Services to give us the expert health advice. But we also, to make sure we had quick access, we had our own infection consultant who would come in and do site visits and check on that we had our dolling and our doffing stations up and in the right place, and staff knew how to use that sort of procedures. We had assurance. So one thing I think when you look at a prison system, 16 sites and thousands of staff, you're only as strong as your weakest link. So how do you make sure your communication's really clear, people are trained, they know what they're doing, and you're checking that things are actually happening as you think that they should be happening and as your policies and procedures say. So we're quite active in the assurance of going on the ground and seeing that we were actually implementing our policies and procedures, and PPE as was required. We moved to requiring masks before the community was required to wear masks in our workforce back in May. I think we moved to that. So one was a bit of integrated response in terms of, the health advice, but ultimately being operational decisions, given we are responsible for the safety and security of people in our care, the Commissioner and the Secretary of the Department of Justice. It was pretty clear we had one line of responsibility, which was through the Commissioner to the Secretary. This wasn't a time for matrix accountability. It was a bit of a command and control structure. And I think when you are making decisions, and we're making decisions in minutes, when you get a code, we had one thing I didn't mention, we had about, I think it was 6 staff that tested positive during COVID wave 2. Then that one way's more concerning. The quickness of what do you do and precautionary, who do you furlough while you wait and further analyse what's going on. So that idea of containing while you actually get a sense of what's going on and being really cautionary, and that was something that served us really well as well. We set up a task force of staff, of a small team of dedicated task force, which was absolutely integral, because there's no way people can do this on top of their normal job. We needed a group that we would all know who to go to, who would lead, who would coordinate it, lead up, talk to the general managers, to the teams in the prisons, talk to the executive, and really be that one point of focus for all things to do with COVID-19. And that was a critical factor in that process. I think I've talked about governance in terms of structure and clarity of lines and responsibilities. The other thing is we do have a human rights charter in Victoria, and we were, certainly looking at our decisions against an assessment against that charter, and how do you balance the least restrictive, but also having the precautionary risks to the very real risk of the impact of COVID should it get into your prison system. The other thing I think that worked well is the fact that we were able to mobilise the technology quite quickly. When we suspended visits, we suspended them with 200 tablets rolled out to support family connection, and prisoners have actually loved that. We've had 60,000 more Zoom visits between May and November this year than the same time last year. If you compare it to face-to-face visits, we have over 130,000 Zoom visits. Prisoners reported they could see their dog, they could see the kid doing their homework in the dining room table, and so that we've had a really positive response to that. Even for service provision, we found for some things, the one-off assessment it worked really well for people as well. So one of our lessons, I guess, is how do we incorporate that technology going forward? It kind of prompted us to move more quickly than we would have otherwise. And certainly Zoom visits are here to stay, and we integrate them with face-to-face visits, knowing that you need both, and both are really important for people. So we go to the next slides, Stuart. I think I talked about one of our challenges going forward is probably maintaining our diligence. We are not out of the woods. And you just see that today with Victoria having, a positive hotel quarantine worker having tested positive that's been in the community during that time frame. So we are conscious of that. How do we maintain that? How do we make sure staff aren't wearing their masks under their nose? Just things like that. When you've got 3,000 staff, and if I see one more person with their mask under their nose, I'm going to get really annoyed. So that's I think a really important one. Maintaining our ability as an organisation to respond quickly and not get tired. And I think our other challenge is how do we continue with our longer term agenda? Because there was a while then when everything was COVID. And you drop some of that broader reform that you're trying to do. We're clearly working on vaccination and working with the Department of Health and Human Services in terms of the scheduling and how we will roll out vaccination of prisoners and also the staff that work in correctional facilities as well, as a big priority coming forward over the next few months. And the ongoing component about we are in a COVID world for at least a year or two until you really have that widespread immunisation that actually works and effective. So how do we continue to adjust our service provision and respond to outbreaks as they occur in a way that's proportionate but also safe for everyone? So I think that's probably some of our challenges. And getting the balance right. It is really difficult, almost as you come out of stuff. You get a lot of questions, why are you still doing this, etc. And have we got that balance right? And how do we test that balance is the right balance? How do we improve the experience of people who are in protective quarantine is another focus, that we're thinking throughout that process too. Longer term, we have had a 12% drop in our numbers, so it's understanding what that means in terms of our prison numbers and what will continue, what's the impact on the broader criminal justice system. A lot of tally court, when I talked about remote service provision, I think something like 97% of court hearings or even higher moved to tally court during COVID. From being, where we'd have to take the prisoner to the court process, an extraordinary quick adaptation to a telecourt process. And interesting enough, prisoners actually like telecourt. So while I think often the lawyers and judiciary sometimes, say concerned about it. What you hear back from prisoners is, when I go to court, I have to wake up at 6 in the morning. I have to wait along on the bus that picks up everyone else. I'm then held in a cell with people that I don't know and that I don't like. I'm stressed. I go to court. If I get bad news, I go back to the cell. I'm waiting. I've got no phone call to call anyone, and then I have to wait on the van, get strip searched on the way in and out. If I go to telecourt, it's half an hour out of my day. I go into telecourt now, get bad news, I've got my mates around me and I can talk to them about it. So I think that's kind of interesting too, those experiences of people in terms of what's good that we should take going forward in partnership with our stakeholders. And I guess the other one is our ongoing preparedness. If it's not COVID-19, it's flu or it's cold. So, and we're not a health provider, so I think, do need to pay my respect to our staff in terms of their response to infection control and PPE, in terms of how they really did respond to that kind of component and kept the prison system safe during that process. But for us, it's a longer term issue. How do we embed this as business as usual and have it probably more of a focus of our work going forward? I'm not sure I've met 7 minutes, Stuart, but that's where I was going to probably leave it, to say that COVID did become very real, that we were able to stop prisoner-to-prison transmission despite having 24 prisoners with COVID and 6 staff that tested positive to COVID, and to probably thank the work of prisoners and their families who were incredibly understanding of the changes that we made and really did understand it, to all of our staff who did a fantastic job, and our stakeholders too.
Thanks very much, Larissa. You've provided a ton of useful information there in a short period of time. I'm sure there will be a number of things that we'll pick up on again in the discussion. Certainly for me, the information about Zoom visits and telecourt and how that came to be and how you see that moving forward is fascinating to hear some of those details. Just a reminder to the audience, please continue sending in questions, comments. If there's anything that you want Larissa to respond to, please send that through, and Lucas will compile those for our Q&A session. So moving straight along to our second speaker, it's a real pleasure to introduce from across the ditch, John Hancock, who's works for the New Zealand Human Rights Commission. With no further ado, John, I'll hand over to you.
Thank you, Stuart, and tēnā koutou katoa. It's a pleasure to be able to speak with you all about these important issues and these new challenges that different aspects of the system have faced over the last 12 months. So Stuart, if we just move to the next slide, I'll just provide you with an initial overview of the OPCAT monitoring system in New Zealand. So this is where the Human Rights Commission comes in. So in New Zealand, we have a multi-body national preventative mechanism that was established in 2007 that does the monitoring under the optional protocol under the Convention Against Torture in New Zealand. So there are 5 different institutions that do that. The principal NPM for monitoring prisons is the Ombudsman, who also monitors a number of other places of detention that you can see there on the slide. The Children's Commissioner, who has a focus on facilities for children and young people, the chair of the Independent Police Conduct Authority, who monitors police cells and persons otherwise in police detention, and the Inspector of Penal Service Establishments, which is looking at Defence Force detention. And the Human Rights Commission, where I work, we're the central national preventative mechanism. So we don't do the monitoring ourselves, but we have a coordination role. And just move to the next slide. This just provides an overview about the New Zealand system. So the National Preventative Mechanism system in New Zealand is vested under the Crimes of Torture Act. That provides that the National Preventative Mechanisms have unrestricted access, and that's quite an important issue when thinking about the implications of lockdown to any places of detention for which they are designated. And then also the second major bullet point there, the designations that the National Preventative Mechanisms have are gazetted. For example, you see the last bullet point there, managed isolation and quarantine facilities, community-based remand care homes, public protection order residences, so other types of places of detention that weren't originally covered are brought in under the ambit of each national preventative mechanism by way of gazette. So yeah, just move to the next slide. So OPCAT monitoring during the pandemic. So New Zealand's most acute phase was alert level 4, which was the nationwide lockdown that occurred in late March through to late April. It was, I think New Zealand had one of the more sort of restrictive lockdowns compared to other countries during that time, during that sort of first wave of the COVID pandemic. And it created some issues for the monitoring agencies because access to prisons were restricted. So national preventative mechanisms such as the Ombudsman, such as and other organisations like ourselves were not did not have rights of access. We were not initially deemed essential services. So the monitoring function itself was immediately impacted by the lockdown, and it was an issue that was raised with us, and we wrote to the Department of Corrections Chief Executive about that, raising various issues related to the impacts of the lockdown on monitoring. So there's immediate sort of impact there. So what had to happen is that more innovative ways of monitoring, remote monitoring, were put in place, usually video-based, and that those in themselves were interesting and created new modes for being able to communicate. But initially, it was difficult for monitoring to be able to take place. Then later on, in June 2020, the Chief Ombudsman announced he would undertake monitoring of the MIQ facilities. So these are the managed isolation and quarantine facilities. So under his health and disability designation. So next slide, Stuart. So alert level 3, so that was the next, was still quite a significant and severe level of restriction. But it did enable the Ombudsman to take on-site visits. So during that first lockdown, level 4, there was no on-site inspections, but alert level 3 enabled agencies to be able to, that were not essential, to be able to undertake inspections of places of detention, including prisons. And then from the 13th of May, the lockdown levels decreased further, and most on-site OPCAT inspections by the agencies recommenced. So next slide. Now I've raised this as a case study, or as an interesting aspect of COVID-19. There was a community outbreak in Auckland in August last year, and what it meant is that the Auckland region moved back to alert level 3. So we'd all been living in relatively unrestricted circumstances, and then suddenly we were back in alert level 3, which is pretty much lockdown for everyone. And one of the interesting aspects of this was that there was the introduction of compulsory detention in MIQ facilities for people who tested positive for COVID-19, which was not a public health measure that had been used during the level 4 acute phase of the lockdown. And it was quite unusual the way it was managed. The government had been doing a pretty good job of being transparent about the legal measures that it was using for lockdown measures and for its general public health response. But there was a lack of transparency around the legal basis for this particular lockdown. It did have a basis under the Health Act, but it had not been, it was not vested under the new COVID public health response legislation that had been passed by urgency earlier that year in May. And one of the issues about this compulsory detention in MIQ facilities was that it had a disproportionate impact on vulnerable and marginalised communities, because it was focused on South Auckland, where there's a large population of Māori and Pacific people who in lower socioeconomic circumstances. And it was evident of the I guess one of the issues that's come out of the COVID crisis has been expeditious decision making, and the impact that has on human rights principles such as legality, proportionality, and necessity. And in this case, from a human rights perspective, we were concerned that a measure of this nature that was, required people to go into a mode of detention had not been made particularly clear or transparent to the public. And however, we wrote to the minister about it and were provided with information which we were then able to respond to and distribute. So this, I guess, gives rise to the key issues, opportunities, and challenges from that COVID-19, I think, has meant for detention and monitoring of places of detention. And the first is obviously the issue around access, ensuring that national preventive mechanisms, other types of monitoring agencies, and other types of statutory entities, such as visiting justices, are able to continue the important monitoring work they do during a pandemic. I think that's a very important issue. Following on from that, I think it's very important for detaining agencies to plan and integrate monitoring processes into their emergency planning. I think it's probably seen as an adjunct to their core work, but actually should be seen as integral to the overall detention system, because of course the monitoring of places of detention is a human rights obligation. It's a it brings about minimum human rights standards, and so it should be factored in to emergency planning for situations such as this. In terms of opportunities, we've seen it's brought about new innovative modes for engaging, such as video monitoring. In fact, the Children's Commissioner found that under his jurisdiction, that the video monitoring was received positively by a number of the young people in care and protection residences and in youth justice residences. In terms of things that were missing from the response, again, I think there was initially a lack of visibility of human rights and Treaty of Waitangi obligations in the response. That can be perhaps excused in the initial phase where agencies were having to respond under extraordinary circumstances. But I think now that this has happened, it provides an opportunity for policymakers, legislators, and departments themselves to ensure that their human rights obligations and commitments are fully integrated into their policies and practices and operational systems. Because of course, if those are missing from a response, that impacts on the rights of prisoners, it impacts on the rights of the abilities of NPMs to undertake monitoring, and that impacts on the availability of safeguards. And so moving to what the biggest priorities that we think have arisen from the situation is first ensuring integration of monitoring into planning and responses, ensuring that legal measures that are taken are transparent, and ensuring that human rights are visible in those measures and in the policies and practices that apply. So that concludes my talk. Thank you very much.
Thanks very much, John. It's great to get that perspective. And again, a couple of things that we may wish to sort of pull out again in the Q&A is just striking that balance between the human rights obligations versus the necessity of rapid responses and how to navigate that. And just drawing a thread to Larissa's presentation, the use of video monitoring and how new technologies may be integrated into what happens going forward. So certainly something to come back to, but thanks very much for that. So our third speaker today is Dr. Erik Monasterio from the South Island of New Zealand, from the Canterbury Regional Forensic Service and the University of Otago. Erik doesn't have a PowerPoint, so I'm going to unshare the screen so we can listen to Erik. Over to you.
Thank you very much, and thank you for inviting me to Tēnā koutou katoa. I would like to give a brief perspective from a specialist mental health perspective on how we work together with the correction services in order to minimize the risk of COVID coming into prison and also coming into our forensic psychiatric facilities, which are particularly vulnerable to this infection because we have a population of patients who are at high risk from COVID complications. I would like to talk by presenting my views in 4 stages, really, sort of background or key issues, the challenges that came before us with COVID, our response, and then the outcome. And I guess the background for us was similar for the rest of the world, really. It was, how do you manage with a rapidly progressing pandemic crisis with data emerging day by day? And particularly, how do you respond in these big institutions, which are often centralized and not that dynamic in responding to these sorts of crises? Behind that, and particular to New Zealand, is that over the last 15 years, we've had a rapid and unprecedented growth in our prison population, which has led to considerable debate about how often we incarcerate people in New Zealand. And it may be interesting for our viewers to know that relative to our population in New Zealand, we incarcerate 30% more people than in Australia. So significantly higher population in prisons here. And we have the 7th highest incarceration rate in the OECD. Because of the growth in the prison population, the rapid growth in New Zealand, it means that in general, prisons are outdated, overcrowded, and in many ways are the right places for these sorts of pandemics to go wild. So that really created a significant background challenge for us, and not least of which is that the New Zealand prison population is made up of 50% Māori, who only make up about 15% of the population. And we know that Māori are particularly at risk for the complications arising from this infection. So in terms of the challenge before us, as we know, the pandemic developed really quickly. And in New Zealand, we announced a pretty drastic total lockdown measure. The first community case in New Zealand occurred on the 28th of February last year. By the 21st of March, the government announced a 4-level response. Level 4 was a total lockdown. So in essence, we had 4 days from the moment the government announced its lockdown response to put into interventions in place to manage this situation in a custodial and a health setting. The level 4 total lockdown, which pretty much prevented entry and exit from prison, was in place from the 25th of March to the 27th of April last year. So that gave very little time to plan. Because of the centralized structure of the correction services, they really struggled with this. On the 20th of March, I visited the prison, and there was very little in the way of information or advice as to how the pandemic should be managed. There was no signage in the prison. There was no PPE. There wasn't even any advice on social distancing. So we had to work very quickly. We were concerned that we were going to miss the boat in terms of trying to put interventions into place to stop the infection coming into prison and eventually into hospital. And the most important thing to bear in mind is that at the outset, our aim was to slow down the rate of infection transfer. We never thought we would stop the pandemic entering the prison or the hospital system. So what was our response? We very quickly came up with a set of responses that we applied to all forensic services and all prisons around New Zealand. We immediately developed a new triage systems for routine prison assessments, which involved us not having contact with prisoners. We also set up an agreement with corrections that there would be a compulsory health screening process before we saw anyone in custody if we needed to see people under urgency. And they followed the usual health precautions, such as taking a person's temperature and ensuring that they were free of symptoms. We also aimed to put into place a requirement that if anyone became so unwell in prison, before they came into hospital, they would have to have a COVID screening test done. And that met with opposition, which is a real concern to us. So our proposal that nobody should come into hospital without a negative test was not accepted because of the shortage of availability of testing processes. What we mainly relied on was technology. So we very quickly adapted to utilizing telephones and AVL technology. And interestingly enough, the adaptation of AVL or audiovisual link technology was very slow to be picked up in custody. So most of our assessments in the first couple of weeks were done via the telephone rather than via AVL. For the few really urgent cases that we felt we needed to have more direct contact with prisoners, we arranged for us to see them behind a physical screen, such as a perspex screen, or maintaining considerable social distancing by seeing them in big open plan offices within the custodial setting. We also set up a specific prison team. So that was within our forensic service. We had 5 designated staff who would only work in the prison service, and we avoided them having any other contact with other members of our forensic team. That was to decrease any risk of transmission of infection should that occur. At that stage, we didn't have sufficient PPE to provide to our staff to go into prisons, so they utilized different items of clothing when they were in prison to when they left. So we adapted a PPE system, if you like. The prison system, as in Victoria, set up isolation facilities for all new receptions into prison to ensure that if they tested positive for COVID, they wouldn't transfer it to the rest of the prison. And in all the South Island and Canterbury prisons, there was not a single case of COVID entered into the prison system. What made our interventions so successful, really, was the ability to work closely between people rather than relying on process and policies. So it spoke to the relationship between the health staff and the correction staff. That made a big difference, and it's probably one of the advantages of working in smaller systems, that it allows people to get to know each other better, trust each other, and put into place integrated agreements. So what were the outcomes? We had terrifically good outcomes. I think all of New Zealand was surprised when we pretty much eradicated COVID. We never got it into the hospital system, and we certainly didn't have it in the prison system. In some way, we were very lucky. Part of that was due to our regional isolation in New Zealand, sitting at the bottom of the Pacific. Our interventions were good, but we also relied on good luck. Part of my concern going forward is that we were so successful, that part of that success was due to the lack of our regional isolation, that in many ways we're very slow to adapt to the responses that will be required for future pandemics. We're still struggling with the development of AVL technology into the custodial setting. So that is an area that requires considerable work. Our prison population remains significantly high, and we still have a high rate of remand prisoners in custody who going forward are likely to place a considerable risk for infection should there be community infections or other pandemics going forward. I would like to just finish by saying that the integration between corrections and health services led to a very favorable response so far, but it is important that we don't forget that there is a risk of future community transmission and also the risk of future pandemics. That means that we need to go back and put into place a lot of the initiatives we talked about in relation to containing this, particularly the use of AVL technology. And in particular, New Zealand really needs to look about decreasing its incarceration rate because it's very, very high. Thank you for that.
Thanks very much, Erik. And again, you've covered a lot of ground there. And I know we've been getting a few comments and questions coming in through the Q&A, so much that we could come back to. One of the things that made my ears prick up is the comment towards the end there about the integration of health and correctional services. And again, I think I'd be really keen for us to circle back to that in the Q&A, perhaps also asking Larissa, who in her previous life was Director of Justice Health, so I think can talk from a very experienced perspective about that sort of integration stuff. But thank you very much again. So with no further ado, if I can make the technology work, I'll move on to our fourth speaker for today, who is Roxanne Moore from NATSILS. Roxanne, over to you.
Thank you, and thanks for having me today. And I'd like to acknowledge that I am on Kulin land and acknowledge the traditional custodians, elders past, present, and Aboriginal people listening in today. When asked to speak today, I immediately thought of this quote from Arundhati Roy, where she describes the pandemic as a portal, a chance to break with the past and imagine the world anew. So we're at the door to this portal, and then George Floyd's life is crushed out of him by police, and the Black Lives Matter movement sweeps across the globe. And this combination of COVID and Black Lives Matter provides a critical moment for all countries to reconsider their carceral politics. The US, Canada, Indonesia, Iran, Turkey, UK, to name a few, all released thousands of imprisoned peoples and changed their practices of policing, diversion and bail. But instead of taking the opportunity to reimagine the justice system here in Australia, our political leaders, police and army officers marched through that portal with handcuffs, serious fines, violent arrests caught on camera, racism, solitary confinement, and there's evidence that they targeted First Nations people, communities of colour and communities living in poverty. In April, Yorta Yorta and Muddy Money man Dwayne Kennedy was told he did not need to attend court due to COVID. In what the judge described as a string of errors, a warrant was issued for his arrest. And when he was found asleep on a park bench close to his home, he was fined $1,652 for being outside during COVID. He spent 2 weeks in prison, denied bail twice. He had an acquired brain injury and cognitive and mental health issues. And his sister had died in custody on remand just months earlier. The judge noted that the warrant was not required and that he was at a greater risk of serious infection from the COVID-19 virus. Our people make up 3% of the total population, but 28% of the prison population, and we are more vulnerable to contracting and dying from COVID-19 in prisons due to chronic health conditions. And worldwide, there have been over 3,800 deaths of imprisoned people in 47 countries. It was for this reason that Michaela Reynolds started a petition which has now received over 23,000 signatures. In 2018, her brother Nathan Reynolds, only 36, died in custody after having an asthma attack. Michaela says, if prisons couldn't cope with my brother's medical emergency back then, how will they cope with an outbreak of coronavirus? We know the potential of COVID to spread through prisons like wildfire. And since April 2020, in 4 open letters, her calls were echoed by families whose loved ones have died in custody and over 400 legal professionals and NATSILS repeatedly calling for governments to responsibly release First Nations people and those most at risk to reduce prison population as the most effective way of managing the risk of COVID-19 outbreaks in prisons. This risk is very real for our people, and an Aboriginal mother whose daughter was in prison with a heart condition and acute brain injury in April said, I'm really worried about COVID-19. If she was to come into contact with it, it'd probably kill her. And there have been multiple COVID-19 prison outbreaks and cases Victoria, Queensland, New South Wales. In response, governments have implemented measures like lockdowns, extended periods of isolation or solitary confinement. And as we heard earlier, limits around suspended visits, access to family, phones, services, lawyers, counsellors. New imprisoned people were quarantined and some imprisoned people were forced to clean, and there were makeshift hospitals set up in some prisons. Some did not even have access to soap. Sparky, a community campaign we're involved in called Clean Out Prisons, and these measures raised serious human rights concerns. There was legislation passed to release people from prison in New South Wales, but it wasn't utilised. There have been reductions in prison numbers in Victoria and New South Wales, but this has largely been because lawyers have been successfully applying for bail rather than from release of prisons. There have also been some reductions in police bail, but overwhelmingly, we have not seen governments taking a decarceration approach to the pandemic. Rather, they have been policing and imprisoning the pandemic. But I acknowledge that, as we heard earlier, there are a number of considerations and serious risks and factors at play. But we have serious concerns, particularly around the breach of children's rights in prison during COVID. So 19 children tested positive for COVID in Victorian youth prisons, to our knowledge, and were held in isolation for weeks. A cluster at Brisbane Youth Detention Centre resulted in 130 children as young as 13 being held in solitary confinement. And we know that the majority of children in prison are First Nations children. No child belongs in prison, especially not during a pandemic. Harsh practices are likely to have an irreversible developmental and mental health impacts on children during the pandemic. Police have been given unprecedented emergency and discretionary powers. The Army has been sent into communities. 2.3 million in COVID fines have gone to young people in Victoria, and Aboriginal people disproportionately impacted with those fines generally. These powers have been used also to limit the democratic right to protest, with Black Lives Matter protests and organisers and attendees in some states being fined and arrested, despite no evidence of community transmission from these protests. Here in Victoria, we saw a sacred Japarong tree destroyed during stage 4 lockdowns, and 50 protesters were arrested and or fined. And meanwhile, we have seen concerted efforts continue to keep events like the football and the Australian Open proceeding. The evidence of the fines pointed to racial discrimination and targeting, and I note the work of Osman Faruqi in the Saturday paper where this graph shown comes from. Suburbs with the most fines were the poorest, with no correlation to where most COVID cases were. This was true in New South Wales and in Victoria. But there was a correlation to high populations of First Nations people, communities of colour, and communities of colour. In Tennant Creek, for example, in the NT, COVID fines were used to move Indigenous people out of overcrowded homes. Most recently in Victoria, police officers who issued fines for breaches of COVID have been instructed to replace those fines with cautions instead. So, especially with the huge court delays that we're now experiencing and the ongoing threat of coronavirus is increasing the need for urgent decarceration strategies, which we've been calling for throughout the pandemic, including public housing, income support, community-controlled and culturally safe legal, family, health, disability and women's services. And these new, more infectious strains of COVID that we're seeing now, which are harder to contain and pose greater risk to community transmission, also increase the need to implement justice strategies which protect prisoners and people in prison and communities. There are urgent calls to reform bail laws, to repeal mandatory sentencing and offences of public drunkenness and imprisonment for unpaid fines, and to raise the age of criminal responsibility to at least 14 years. So there is still opportunity for us to walk through the portal into a better future for us all, with a public health rather than carceral response. This pandemic is not going away anytime soon. But the question is there the political will? And in the words of Roxanne Gay, eventually doctors will find a coronavirus vaccine, but Black people will continue to wait for a cure for racism. Thank you.
Thank you very much, Roxanne. Some really powerful words there, and I'm sure a great deal that we'll want to come back to in the Q&A. A couple of things that really resonated for me is firstly that you're putting a human face to this. We're talking about people and families and some very tragic circumstances, and thank you for that reminder. I'm also grateful that you brought up youth detention in this context and some of the issues around isolation for vulnerable young people in those settings and the Raise the Age campaign and all of the related issues. So thank you very much. And again, that's something we'll come back to. I'll move on to our final speaker for the webinar today, who is Dr. Mindy Sotiri from the Justice Reform Initiative. Mindy doesn't have a PowerPoint, so I'll just revert to the normal screen and over to you, Mindy.
Thank you so much, Stuart. Thank you so much to Roxy and all the other speakers. Thanks for having me here to talk. I want to acknowledge the Gadigal people whose lands I'm living and working on today, and pay my respects to elders past and present, and to all Aboriginal Torres Strait Islander people who are joining this meeting today. I'm going to talk about two issues, and I think Roxy's probably covered one of them sort of beautifully, so I might spend less time on that and more on the second one. So the first is decarceration, and the second is really about building community-based responses to populations leaving prison and how these things interact. And I want to look at both of these things from an advocacy perspective. That is, I want to try and unpack within each of these what the sort of exceptional circumstance of COVID has illuminated, I suppose, in terms of both gaps in existing service systems, and also what some of the levers might be that COVID has highlighted in terms of being able to bring about change, especially in terms of reducing incarceration. So in terms of decarceration, I know there's been a whole seminar on this, so I'm not going to go into any detail really in terms of the numbers, but I want to think through what it opens up in terms of advocacy and reform, and what possibilities it might open up in terms of how we think about reducing prisoner numbers. So we know from the ABS data across Australia that we have seen a really significant decrease in the prisoner population, more than 5% for the first time in 11 years. And in some jurisdictions like Victoria and also like in New South Wales, there was a really sharp decline just between March and May, so more than 15% reduction in New South Wales. And we can see in some jurisdictions, of course, that the numbers are now creeping up again, although very interested to hear from New Zealand about why that's not happening there. So I'd love to talk about that later. So of course we know that this reduction, this kind of dramatic decarceration happened during an unprecedented public health crisis. And we know that a lot of the reductions can be attributed to postponements and court appearances. And we also know that there were, in some states and territories, some significant reductions in some crime categories, or at least crimes that were detected or reported to police. And as Roxy's pointed out, there was some over-policing and over-criminalisation in particularly Aboriginal and Torres Strait Islander communities. But I think that what I want to talk about here is the way in which this sort of fast and dramatic decarceration forced, I think, all of us, including people running, prison administrators as well as political leaders, at a time when it looked like when we were really being faced with a public health threat that would no doubt extend beyond the prison gates at that point. And it was quite a short period. Our leaders, I think, did start listening to advocates who were saying, how do we keep people out of prison? We need to come up with some different strategies. The fact of responding to that question, as happened in New South Wales with the enacting of the legislation, and as was certainly on the table in a number of different jurisdictions, is, I think, significant. We saw in response to this question in some jurisdictions, really, and certainly in New South Wales, quite significant shifts in terms of policing practices, bail practices and parole practices, although, some states obviously did enable early releases, but it never happened. But I guess the point here is that most of the policy and practice shifts that drove down prisoner numbers dramatically actually occurred within existing legislative and policy frameworks. And of course, there's a million other things that need to happen outside of the justice system to break cycles of disadvantage and imprisonment. And that's sort of really where I want to head to with the second bit of this argument. But I think that what the decarceration did show us is that over-incarceration really is a policy choice. It's not an inevitability, and it's not a wicked policy problem. We can see significant reduction in the reliance of prisons occur with absolutely no impact on public safety. In fact, we saw, of course, thousands of people in the community during COVID who, and this is, I was working in the sector at the time, we saw it with many of our clients, many people that wouldn't have been granted bail, that would have spent longer on parole living on the community, and we saw a decrease in crime over this period. And again, I think there's a number of different ways of coming at this, but really, I think Roxy said it, the thing that's actually required to drive the change is political will. So I think as we're thinking through COVID, or when we're thinking through decarceration, whether that's in the context of COVID or not, we need to think about how we can harness this political will. And as the crisis sort of abates and prisoner numbers again begin to creep up in a number of jurisdictions, I think we need to start to continue to build a case for dramatically reducing our prisoner population and also really embedding sustainable alternatives. And I guess this is the sort of the second part of the puzzle, and that is the way that justice reform and decarceration doesn't and absolutely can't exist in a vacuum, and the way that it really needs to interact with other kinds of social service reform. I think COVID highlighted this in quite a dramatic way when it came to the question of early release, or in fact, and that debate around early release, or in fact, the fact of people leaving prison in larger numbers than usual. Or the way, in fact, that people who were perhaps criminalised or managed in prison settings sort of were now kind of in the community. A lot of us who were working in the community sector observed that there was this sort of disconnect between the ambition to decarcerate and also a real anxiety about how services on the outside might in fact cope with an influx of people from prison. There was even in some jurisdictions a little bit of a pushback on the part of some homelessness sectors about the need to release people from prison because services felt ill-equipped and ill-resourced to cope. And there were frequently sentiments expressed about how in fact people might be better off in prison than they would be homeless in the community. And I think that what this tells us and what COVID has highlighted is that we've got an enormous problem if we've come to rely so heavily on incarceration for populations who we know have so often experienced significant disadvantage and who have so often been criminalised, managed in justice system settings, rather than genuinely actually having opportunities to live in the community, be supported in the community. We've come to rely so heavily on prisons that even during a time of pandemic, there's anxiety about what decarceration might actually look like. So of course, during COVID, we had people leaving prison into homelessness, but we always had people leaving prison into homelessness. We had people leaving prison with half a Centrelink check and nowhere to go, as we always do. We had people who desperately needed help and no one to speak to, as we always do. We had people with desperate need for mental health and AOD and disability services, as we do. We had a desperate need for culturally safe support and Aboriginal-led support for Aboriginal communities, as we always do. So in one sense, there was sort of a half appetite for decarceration, but on the other hand, there was almost nothing that was really shifting in the community in terms of resourcing to be able to actually make decarceration a possibility. So I think the fact of the pandemic and the associated shifts at times to service delivery made it feel like a crisis, certainly for people that were working in that space and for people. But the reality is it's kind of always a crisis for people leaving prison. I think that we know that we need decarceration to reduce public health risk. We know that overcrowded prisons have far less access to critical preventative measures like hand washing and hand sanitizer and social distancing. And we also, of course, know that prisoner populations have much higher rates of chronic health conditions. And I think our attention needed and was rightly focused on options for decarceration. But we didn't necessarily do as well as a community, I don't think, in terms of thinking through the reality for people when they're released from prison and then responding to this accordingly. And I think this highlights a pattern more generally, and that is that justice reform and decarceration, although it has to be about legislative change in sentencing reform, bail, parole, sentencing and policing practices, although all of those things need reform in order to actually stop so many people unnecessarily entering our crowded prison systems, but it can't operate in a vacuum. It needs to happen in tandem with really significant social service, health and service sector reform. So while I think COVID highlighted our capacity and ability and in some jurisdictions slightly unexpected appetite in the face of a crisis to get people out of prison, perhaps even though we didn't succeed with that, there was an appetite there for a minute. Perhaps what it also highlighted is the second piece of the justice reform puzzle, and that really is around building community. And I think that well, we can see very clearly that there are mechanisms that are quite easily accessible to reduce the numbers of people in prison. We need to look at those, and I think COVID's forced us to look at those also in the context of the need for support when people are actually living in the community. That's it from me.
Thank you very much, Mindy. That's again, you've managed to pack a great deal into a few minutes of speaking there. A lot of that really resonated with me, and the importance of investing in community in order to achieve decarceration as a policy objective. A phrase that really stuck with me is over-incarceration is a policy choice. I wrote that down and might put that on a t-shirt or something. It's quite a compelling argument. One thing that we might want to tease out in the Q&A, and I'll hand over to Lucas in a moment, is you pointed to the fact that in the context of decarceration, we didn't see crime rates increase, and that goes to, well, maybe we don't need to incarcerate people. One important piece of context around that, I wonder if it is that it was a very unusual situation. For example, we know in the last 12 months in a number of countries, including Australia, there have been substantial declines in self-harm, or at least self-harm presentations to the emergency department. And I don't think that's because the lockdown has been great for people's mental health. And so, of course, it begs the question, is the reduction in crime that or the lack of an increase in crime that we've seen in the context of this unique decarceration event something that's sustainable once we return to a more normal world? That's probably a very big question, and perhaps one that I might invite Lucas to kind of tease out with the whole panel, but certainly, Mindy, I'd be keen to hear your thoughts on that. Look, that's it from our speakers. Thank you very, very much to all of you. There's so much information there that we've managed to distill. I'll hand over at this time to Lucas, who's been compiling some questions from the audience to facilitate some Q&A. Lucas, over to you.
Thanks, Stuart, and thanks to all the panelists. Very good to have such a rich variety of views on such an important topic. We got quite a few questions, actually. I would like to start with one that Stuart commented on, but we got some comments from the audience as well, in how to achieve the better integration of correction services and public health services. And we got a comment from the audience I would like to comment on, which is prison health is public health. So Larissa, could you start with that one, please?
Sure. Yeah, I'm just trying to think what to comment. Prison health is public. I mean, you're right. I think prisons are very aware that they're a unique environment from a public health risk perspective, whether it's bloodborne viruses or droplet type viruses that we primarily have at the moment. I think in Victoria, our structure is a little bit different. So we have a separate Justice Health Unit that is in the Department of Justice. They're not part of corrections, but it was fantastic for us in the sense that we had on our fingertips, and they were working the same hours as we were in terms of the health advice, and then they would link into the public health branch within DHHS. So it gave us a better access and avenue to when you needed to go through that than us trying to navigate our way, not having our own health staff that could support us in terms of the advice of how we should react to that process. We were very aware, of our heightened risk if we got, I guess, COVID into the prison system, but also that of our risk to the community in terms of also being responsible in how we release people. So I think it is right. I think it's really about how you make it work for you. And I think certainly in Victoria, and I do need to shout out to the Justice Health colleagues in terms of how they supported us. We had them on tap. I think there would have been times because, Victoria was in a different situation than most of the other jurisdictions in this conference. The public health branch was very, very busy. They had other stuff as well. So for us to have people on tap was actually absolutely critical for us to be able to respond rapidly and feel confident in what we're doing. But yeah, absolutely accept that public health, and we know we have higher rates of different communicable diseases within prison populations, and how do we respond to that?
Fantastic. Any other panelists would like to comment on that?
I just wouldn't mind saying that I think the issue of access to Medicare for people inside prison in Australia is a really critical one to look at if we are serious about ensuring a kind of equity of healthcare inside prisons and outside.
I think as a principle it's important, but I can only talk to Victoria, but the access to GPs, to psychiatrists, to mental health nurses, to dentists in Victorian prisons is better than people get in the community. Now that might say something to your point about how do we step up in the social services and health services in the community, take your point there. But I wouldn't want you to think that people were not able to access healthcare professionals in the prison system.
Look, I would like to make a comment there. Even before the development of COVID, in New Zealand, the government had developed a strategy of seeking to reduce the prison population by 30% over the next decade, which is a very impressive goal to set for itself. What we do know is that prison is a community where there's a very high prevalence of serious mental illness and addiction problems. And the government needs to accept that for whatever drivers, prison is now becoming the receptacle of disadvantage and disease. And the approach to managing this is total integration between corrections and health services. And if you look at the political structure, we have a Minister for Corrections and a Minister for Health. And in some ways, the two ministries are working apart from each other. Understanding the high prevalence of mental disorder in the New Zealand prison setting and the absence of hospital beds to manage that, before COVID, we started an initiative of looking at providing more integrated healthcare into prisons at the earliest possible stage to provide care to people because the resources within the hospital systems are not available to manage that. That is the way forward, I believe. And this pandemic is probably not the only pandemic that's going to occur in our lifetimes if we accept the science behind this. So we have to learn from this pandemic. And if we've had very good results, but we mustn't deceive ourselves into believing that the good results means that our systems are well set up, because they're not. A lot of this is good fortune, and this should be a learning process for us to develop much better integrated services going forward.
A slight counter to that, in the sense that I think you have to be clear about whose responsibility it is and whose duty of care it is, and who cares more about making sure the prison system is safe and prisoners in our care are safe. It is the people who's got that delegation under the Corrections Act, and that's not health. And so when you think about who's got most skin in the game, it is absolutely Justice, Health and Corrections Victoria in the prison system. And then we need to link into and have access to that expertise that we get from other areas such as the Department of Health. So in one way, I guess I'm not quite sure around that. I think that the gap often is about the transition points, the coming in and the coming out, and how you support that and have that appropriately done. But fundamentally, who's responsible for those cares? So the decisions that we made about how we manage the pandemic in the prison system, while they were absolutely informed by health advice and expertise, etc., ultimately we also put that overlay on them about the risk and also the consequence of that risk. Can we manage that risk? If anything, we were probably more conservative than the advice we were getting from the health people. So I think you do have to be clear about who's accountable and responsible a little bit.
Look, and just to counter to that, corrections are good at doing correction things, but they're less good at managing serious mental illness and serious disorders. We know the prevalence is so high that corrections can't manage this. It has to be a partnership, in my view.
Yes.
Yeah, I'm not disagreeing that people with mental illness should not necessarily be in the prison system, but should be in the health system. That's probably slightly different angle.
Yeah, I would like to use that hook. It's a very interesting topic. I would like to hear first from Roxanne and then from John about, so this context of this decarceration, what transition supports and services should be available for people reintegrating the community from prison during this pandemic, but also including their families as well. What do you think, Roxanne, first, please?
Yeah, so I think that public housing is an obvious starting point for that question. And really it's about addressing all of the social injustices for Aboriginal and Torres Strait Islander people that mean that our people are more likely to have contact with the justice system in the first place. So when they are coming out of prison, making sure that there is adequate public housing, that there's a adequate social safety net. And I know that, income support has recently been decreased by the federal government. That there is adequate wraparound culturally safe services in relation to family violence, people with disability, legal services, health services. I think that, there are lots of great programs out there, like the Aboriginal Legal Services across the country run through care programs. So they start working with our mob when they are in prison and then help to, support them when they're getting back into community. But I come back to, really needing to focus on that front end as well. And we are experiencing a huge backlog in the courts with delays, and that is going to have a huge impact on the justice system. So we really need to be making sure that there is active work in diversion into, police practices, so that our people aren't continuing to be over incarcerated during this time, and every effort is being made to reduce the prison population. And if I might just very quickly just respond to some comments made before, I think in relation to healthcare that Aboriginal people receive in prisons, this is often impacted by racism as well. We have certainly received a number of case studies, like through the pandemic, around people, our mob, not getting sufficient medical care in prisons. And one example from New South Wales was a man who had serious asthma, notified staff on several occasions he required an inhaler, but he wasn't provided one, and also suffered from depression, anxiety and PTSD, but was not able to access any of those medications during that period of the pandemic. So yeah, there are really serious health concerns here, and there are also health justice partnerships that are happening around the country that provide that nexus as well.
Thank you very much. John, would you like to give us your perspective on those human rights challenges, and also just a hook to what potentially can be improved? I know a lot of things worked well, but do you think we are prepared for a potential new outbreak in this context?
Yeah, that's a very good question. I think that, the COVID pandemic has brought forward a very important human rights challenge, which was the balancing civil liberties against public health imperatives, and in fact, and so that human rights challenging or balancing act permeated through the through a number of different sectors. Just to follow up from what Roxanne was saying about transitions, I think transitions are incredibly important. I'm not an expert on transitions coming out of the prison system. I did used to work in youth justice, and one of the challenges we had in that sector was transitioning young people out of the youth justice sector, and transitions were generally not done very well and led to people going back into the criminal justice system. And transitions themselves tend to have to engage social services, and when social services are run down or social services don't meet people's economic and social rights, and then the sort of cycle of inequity and systemic discrimination just tends to get perpetuated. And one thing COVID-19 has done is I think it has, on the one hand, it's atomized everybody into our little individual pods for a while, but now that it's at some point it's going to dissipate, and the economic impact that it's going to have is going to be significant. And there's a huge challenge, I think, for government and for the community in the recovery, and because a lot of the inequities, I think, will be all the more acute and evident, and so while it provides a really powerful basis for reform, there are also going to be competing challenges, and it's going to be important for advocates to really ensure that any gains that have been made are built upon during this time. I mean, there was a case, the Borrowdale case, which was a challenge to the New Zealand's lockdown laws. It was brought to the High Court. And what was interesting in that case is that the High Court found that when it came to New Zealand's lockdown policies, that when measuring them against human rights principles, that they met the necessity and proportionality principles, but they did not, initially at least, meet the legality principles. And this sort of gets back to my point earlier on about ensuring that we have, when it comes to the planning, and it comes planning for a pandemic in the future, and when it comes to learning from the processes and challenges that we've just been through, it's ensuring that those that our laws are transparent and are informed by the minimum human rights standards that we have signed up to as a country, and also reflect the policy objectives that the government has set itself. So Erik referred to the New Zealand government's objective of reducing the prison population by 30%. That's an incredibly important objective, but we haven't seen any reform as yet to the sentencing laws and to the bail laws that created the current situation in which we find ourselves. And so I think for advocates, we need to make sure that we're not seeing a whole lot of strategies and decorative public policy, but we're actually seeing tangible legislative action and tangible investment into the social services that are required. And New Zealand has currently we have a housing crisis. So in terms of transitions, again, we have a huge public health waiting list, our social housing waiting lists. The social housing waiting lists of New Zealand they've almost tripled over the last 3 or 4 years, and that was due to decisions that were made years ago that have created bottlenecks. So I think if there's one message, there's one learning. It's about that every situation like COVID was completely unforeseen, and yet it's highlighted a number of cracks in the system, a number of downstream problems that have been created by decisions decades earlier. So it's a chance to try and, I think, really at a deep systemic level address some of these problems. And whether the political will is there, I don't know, but it's certainly, I think it provides an opportunity for advocates to really strongly make the case.
Thanks, John. We have a couple of questions more. I'll see if we get time to get to both of them. But the next one will be about the sort of mental health care support in prisons in Australia and New Zealand, which sounds encouraging according to one audience member. The question goes first to Larissa and then to the others about what the specific situation in Victoria you mentioned about sort of excellent mental health care, and whether there's more information on that and how we can access to data or some information on that? And then I'd like to hear from the others about this topic as well.
So is that in relation to the protected quarantine service or in general mental health care? Because there's probably two different things. There's the normal healthcare, which is primary healthcare, which includes mental health care, and then there's the specialist mental health services that Justice Health run, which I probably was referring to in response to Mindy's discussion around access to healthcare in the prison system. In terms of, I guess, COVID and people in protected quarantine for 14 days, we did implement a proactive wellbeing check-in where we actually used our psychologists and social workers who are primarily there to do our offending behaviour programs, but they do have qualifications in kind of proactive wellbeing and distress interventions as well. So we redirected some of their resourcing to do a check-in and support service of people, knowing that, you know, it is a very different context of being, you know, in a protected quarantine environment for 14 days. So how do we check on how people are going and how they're travelling? So that was, I'm not quite sure of the question, sorry if that helps the response. But all prisons have a health centre and they all have GPs and mental health nurses available through that process as well. So,
thanks.
Not sure I answered it. I'm sorry.
Oh, thank you. No, it's a very, very good response. I think I'd like to hear from the others on the mental health aspect, but also touching on a subject that came in the comments, which is the use of remote hearings and the kind of because that relates to the sort of mental health support to you know, like families as well, and how to deal with that process. And really the question is probably more about what didn't work and how we can improve those approaches in the future.
There's one thing I would note, just having read some of the chats about, it's the court that determines when to use AVL. So it's not the prison system. So it's up to the judge to make the determination of is AVL appropriate, and they should be considering conditions such as, you know, is this actually, you know, the trial, or is it a directions hearing? What's this person's particular ability to work with AVL, or do they need to be there in person and have their lawyer? So that's something that the judge will absolutely be considering. It's their decision, whether it's an AVL or whether it's an in-person presentation. It's not corrections decision.
Erik, would you like to comment on that?
I'll comment on both of them. Look, in relation to mental health and custody, what we know is that there's been a rapid growth in the prison population in the absence of serious violent offending. We're getting a much broader representation of people in prisons, and a lot of those are those suffering from mental illness. There's been two key epidemiological studies done in New Zealand prisons, one in 1999 and one in 2016. And those studies show that there's high prevalence of all major mental illnesses in custody, but increasingly of concern is that the prevalence is increasing rather than decreasing. So unfortunately, prisons are becoming catchment areas for serious mental illness and mental illness. It means that in order to address the inequity and disadvantage, we need more healthcare in prisons, particularly mental health care. And we, all us clinical directors in New Zealand, have labelled the situation of mental health access to treatment in prison as in a crisis state. This is the one area we could do better and should do better. In relation to AVL, when I spoke about AVL previously, I was not talking about AVL for court matters, but in relation to healthcare. And the one thing we did learn very well from our experience during COVID is that AVL technology will significantly improve our access and efficiency of provision of services in the custodial setting. And this is the one area where we're still lagging in putting in additional resources. And we are having discussions with corrections and hoping that we can get this set up. This will make a big difference going forward.
It might be the Wi-Fi. We found that Wi-Fi doesn't always work. I mean, prisons aren't set up for Wi-Fi, and we had to put Wi-Fi boosters in and all sorts of stuff, and that takes time.
Well, look, there are lots of challenges, but I think the technology is there, and we can much more quickly implement the technology, and we should use our experience of COVID last year to really drive an impetus to develop this. The technology is there, it's just overcoming those barriers.
Well, thank you very much, the panelists, for this very insightful discussions. I think I'll hand over to Stuart and perhaps hear the last sort of comments from panelists and close the event. We're about to reach 2 p.m. now.
Thanks very much, Lucas. Look, I want to thank all of our panelists. This is obviously a really complex discussion, and we don't have the time here, unfortunately, to really pull it apart and put it back together again. but I want to thank you each very much for your contributions and for engaging in this. We are a couple of minutes over time, but as is tradition in these webinars, I'm going to invite each of our panelists in a maximum of 30 seconds to provide any closing remarks that they want to. And I'm sorry I didn't give you any advance warning, so you can just say skip if you wish, but I might do that again in the order in which our speakers presented. So first, Larissa, over to you.
I've intended to say skip, but I won't be able to stop myself. I think if we're focusing on COVID, I think certainly in Victoria, and I'm pretty sure in all other Australian states and territories, there was no prisoner to prison transmission of COVID or staff to prisoner transmission of COVID. So I wouldn't like people to leave this thinking that. Obviously, incarceration, who goes into prison, is another bigger and broader issue in of itself. So.
Great. Thanks very much, Larissa. I appreciate it's important to clarify. Second, over to John.
Thank you. Thanks, Stuart. I think the decarceration issue is incredibly important, and just want to acknowledge everyone who raised it today. Getting back to the issue that I presented on regarding safeguards, I just think it's, again, really important that it's acknowledged that the monitoring, the independent monitoring safeguards that we have are maintained and protected as part of the essential part of the overall system, so that for planning for the next pandemic, that those important human rights safeguards are front and centre of any response.
Thanks very much, John. Erik.
Look, I'd like to say that from my perspective, good fortune often leads to good governance. And I think in New Zealand, we have been particularly lucky to have good fortune to the extent to which we were so isolated from COVID. I'm concerned that this, unless we listen to the lessons that are happening internationally, will lead to complacency. I think there will be risk of greater pandemics, and we really need to look at what is happening in prisons and the risk of a future pandemic affecting that environment. Thank you.
Thanks, Erik. Roxanne, over to you.
Thank you. Yes, the panelists have all raised, really important points about the complexity and, the difficult, jobs that government have during this pandemic. However, the pandemic is not going away. The risks of these new strains have such important implications for closed environments like prisons, particularly for Aboriginal and Torres Strait Islander people. The risk is high. We've got concerns about the racial discrimination and implementation of COVID policing practices, just noting like the public housing towers lockdown that we saw in Victoria, and we really need to be focused on decarceration, on stopping the flow of our people into prisons and the justice system during this difficult time, if we are to really walk through that portal and reimagine the justice system for this better world for us.
Thank you, Roxanne. And for the final word, Mindy, over to you.
Thanks so much. Look, I think that despite the best intentions of prison administrators, and despite some remarkable work, and I think there has been some remarkable work that's happened inside our prisons in terms of justice health, and some remarkable luck, as Erik has pointed out, prisons should not be the place where we are dealing with the pandemic, and they should not be the place where we're dealing with mental health. So it's not to sort of diss the work that has happened and is happening inside, but I guess that we need to absolutely have decarceration front and centre of our thinking, which is not to say we don't need to improve things inside prisons, because of course we do, but we need to be thinking about how do we get people out and how do we stop people going in.
Thanks, Mindy. And look, thank you once again to all of our speakers. I could have kept going for ages, but other people may have other things they need to be doing. And thank you to our audience as well for sticking with us and for commenting and adding questions and contributions to this discussion. As I said at the beginning, this webinar will be available on YouTube, but via the link on the Justice Health Unit website. So please check back if you want to go back to anything or want to share that with any friends or colleagues. And just a quick reminder that in the next month or two, we'll be doing the final, the 6th in our series of 6 webinars on COVID-19 and detention, focusing on international responses, not to the exclusion of Australasia, but thinking more broadly about the lessons that we've learned so far and what that means for how we proceed, covering all of the issues we covered today and other issues as well. So please check back, please follow us on Twitter if you want to be a part of that final webinar. Once again, thank you very much. All of our speakers, thank you to the audience, and wish you well, and we'll see you next time.